for the uninitiated, there is a shed load of healthcare data out there. What can we do with it?
An awful lot. So traditionally, data is used for understanding performance of healthcare systems, of hospitals, of geographies within a country. And performance, not just performance management, but to understand the quality and variation in quality. People talk about unwarranted variation. I don't like that term, because unless I have seen every individual patient, I can't tell you whether that variation is warranted or not. So I talk about unexplained variation. There is not sufficient information in the data asset that I have to explain why this hospital appears to be better at delivering this service than that hospital. And I need more data in order to be able to explain that.
Hi, and welcome to the Health Beats podcast, the official podcast of Abu Dhabi Global Healthcare Week. My name is Steve Gardner from Healthcare World magazine, and I'm joined today by Simon Swift, a global healthcare expert who's joined me on stages all over the world, having weird and wonderful conversations about stuff that you can do with healthcare data. Simon has worked in Abu Dhabi, he's worked in the US, he's worked in the UK NHS, and yeah, he is, in my mind, one of my favourite data wonks. Simon, how are you?
I'm very well, thank you. How are you today?
Yeah, very, very well. So look, let's start with the most basic and obvious question we can. Healthcare data, what is it? What do we mean when we use the phrase healthcare data?
Healthcare data nowadays refers to an awful lot of different things that people might not think of as data. There's traditional data in the form of coded information. So this is stuff in data warehouses, all too often, sadly, still in Excel tables, where you have a load of variables about individual patients, nicely ordered in columns, with entries in those columns. And that's the easy stuff, which is collected, created by healthcare systems all across the world. Data nowadays is much wider than that. So if you think of that as structured data, we now have vast amounts, much more unstructured data than structured data. And unstructured data is anything that's not organized that way. So it's free text, so notes written nowadays in electronic medical record systems, imaging, vast troves of imaging from X-rays to CT scans to MRI, ultrasound, and so on. And then you start getting into sort of wider territory. So genetic information that comes out of genetic assays at the individual level, and huge aggregations of that now being created around the world. And then user-generated data, so the kind of thing that we're generating through apps and devices and wearables. All of that is now sort of in the mix to be used in all sorts of weird and wonderful ways.
And used for what? I mean, at the end of the day, for the uninitiated, there is a shed load of healthcare data out there. What can we do with it?
An awful lot. So traditionally, data is used for understanding performance of healthcare systems, of hospitals, of geographies within a country. And performance, not just performance management, but to understand the quality and variation in quality. People talk about unwarranted variation. I don't like that term, because unless I have seen every individual patient, I can't tell you whether that variation is warranted or not. So I talk about unexplained variation. There is not sufficient information in the data asset that I have to explain why this hospital appears to be better at delivering this service than that hospital. And I need more data in order to be able to explain that. It might be that I still can't explain it, at which point it might become something to go and look at. So that's been where data has traditionally been used. We're now getting into a world where there's a lot more predictive analysis done, understanding if these are the circumstances in, well, let's start with this country or this population, then what are the likely things that are going to happen to this population over time? And then you can start to think about what might we do about that. So you can start to shape interventions to mitigate risk in the future. And then at the personal level, you can start to predict individual risks. So this is getting into the personalised and precision medicine neck of the world. What is the risk to this individual, and what might we do in order to mitigate that risk? And then even more fun, and this is where the omics comes in, genomics, proteomics, all of that, is this individual has this particular cancer, let's say. Let's look at the specific genetic variation within those cancer cells within that individual so that we can target that genetic variation with specific drugs that are proven to be effective for cancers with that variation, but not this variation. So you start at a sort of a population level and work all the way down across a continuum of data and use cases.
So this is the clever stuff, basically. This is the fun bit. Yeah,
this is fun.
But in order to, because this is getting into that realm of actually almost predicting the future, being able to understand, what kind of diseases and issues people are going to be dealing with at a population level, and even right at an individual level. But to do that, what volume, quality kind of data do we need? Because this is the problem, isn't it? It's getting the right data to be at the right volumes in order to be able to achieve some of this clever stuff.
Yeah, yes and no. Yes, you need a lot of data. Yes, you need that data to be high quality, by which I mean comprehensive, accurate, valid, all various terms to describe different aspects of quality. But that shouldn't stop us doing stuff now.
Mm-hmm.
There is an awful lot we can do. And if we wait for perfection, we will never get started. So I've worked in this space for 20 odd years, and the data 20 years ago was nowhere near as comprehensive, as accurate, as accessible as it is now. And a lot of the types of data that I talked about a moment ago didn't exist. But there was still an awful lot we could do, and a lot of benefit that could be delivered to health systems and to individuals. There's an awful lot more we can do now. Yes, more is always better, but that doesn't mean don't get started.
So what's the kind of base level? What kind of level of information do you need in order to be able to do that big, clever, predictive stuff?
I don't know. Not very much.
Yeah.
I mean, if I know, the age, sex, and income at aggregate, small geography level for a country, I can start to understand the kind of long-term health risks for that population at a very simplistic level. But you don't need a lot to get started.
I love the fact that, you don't need very much data, just a whole country's age, sex, and income data. That's still quite a lot of data, isn't it?
Nah.
not
Three variables.
Not relatively speaking. But so I mean, where are there examples? Are there pockets of the world where this is being done already? Are there great examples of the way in which data can be used at that kind of predictive level?
Yes, very much so. It depends what we mean by predictive.
Mm-hmm.
A lot of prediction is simply looking at the past and extrapolating a line forwards.
Yeah.
And, the UK has been doing that for a very long time. There's a program in the UK called Right Care, which published a series of atlases, so geographic maps looking at variation in a whole load of different healthcare conditions and services for those conditions across England 10, 12 years ago now. These are available on the public web and are really valuable resources. Those built on the American Dartmouth Atlas of Variation, also publicly available, which looked across America at a relatively granular level, looking at variation in population health and services for the population. So that's a very well-known and trodden approach. These have been used to build predictive work, so looking at demand and capacity, what services are needed where, for which populations, and how do we shape those services effectively. There's been an enormous amount of work looking at quality in healthcare. A lot of countries nowadays, for example, have national processes looking at mortality at a hospital level, and we all saw lots and lots of data about that during COVID. We know that the public aggregators, people like Our World in Data, published vast amounts of publicly accessible data, a lot of which taken from places like the World Health Organization and other international bodies. And then down at the individual level, there are some quite granular tools which will predict individual risk of specific bad outcomes. So things like QRisk3, which is published by a British university, you put in a load of variables about your health, and it will tell you your risk of having a cardiac event over the next 10 years.
Because there's that thing, isn't there, about, it's so interesting that you need all of this information, all of this data across a whole population in order to tell you what the risk is in one individual. Because you're looking at patterns, you're looking at ways in which, that's what it is, isn't it? I mean, at the end of the day, it's looking at patterns, it's spotting patterns, and then understanding what they mean.
Exactly.
Yeah.
It's a mathematical version of the heuristic that doctors learn at medical school, because diagnosis is pattern fitting.
Yeah.
That's what doctors are taught. And this is the mathematical version of the same skill.
At the end of the day, that's the mathematical science of diagnosis. We then start talking about AI and all that kind of sexy stuff. And AI is maths, right?
Yeah. It depends what you mean. AI is poorly defined in most places the term is used. I'm somewhat allergic to the term myself. I think about, there's maths, then there's statistics, then there's machine learning, which is bluntly fancy statistics, and then there's neural nets of various types, which are probability engines. They're mathematical engines.
But they're all fueled by data. They're all fueled by information. And you look at ChatGPT, the whole point is that, ChatGPT ate the internet and then regurgitated what it learned from doing that. I mean, how similar is that to what we're trying to do with all this omics data to try and create complex modeling for what we need to do in healthcare?
That's an interesting one. So large language models are probabilistic predictive engines.
Yeah.
They will predict the next word in a string based on the training data they've been trained on and the previous words in the string, particularly when it comes to the kind of AI solutions used in radiology and image analysis, and increasingly in pathology image analysis, which is a very interesting area. Some of those work in a similar way, but a lot of what people talk about in terms of AI prediction is machine learning rather than neural nets, and is a simpler concept to get your head around and more easily explainable and understandable as to how the computer has arrived at its outcome.
Because this is one of the things that really fascinates me about the whole omics space, is the amount of data and information just in a single human genome. And then you extrapolate that by 100,000 or 1 million. And then you start joining the Genomics England data to the Emirates projects, and the amount of data that you've got to process and the sci-fi in terms of what you could do with all that. That's the bit where you need a really big computer.
Yeah, that's why NVIDIA are making an awful lot of money.
Yeah. How far away from actually using that stuff, and what could we do with that stuff? Because we're not there yet by any means, are we, in terms of being able to use that data to its fullest potential?
No. And fullest potential is an ever-moving goalpost as well.
Yeah.
There will always be new discoveries, new things that can be done. That data is being used, and it's being used in anger. It's being used in clinical practice already, and increasingly so.
So from that point of view then, where are we now in terms of how data is affecting our day-to-day experience in healthcare? And where are we going to be from your point of view in 5 or 10 years?
So it's already affecting your experience of healthcare. Healthcare systems, by and large, across the world, are all resource constrained. Healthcare is an ever-expanding beast that will eat as much money as it possibly can. And those resources are assessed and distributed based on data. What is the demand for what services in this population, and where do we put hospitals, and what services do we put in those hospitals? And that's been going on for decades.
So that's a systemic planning level within a health system, within a healthcare provider. What about for me as a patient, as an individual experiencing healthcare? How much is that affecting my daily life? How much am I seeing my data being used?
Specifically in the UK context, because I know you live in the UK, your primary care doctor has an electronic medical record with your data in it. And there are systems, I don't know if your specific practice uses them, which will constantly trawl through all the patient files and identify patients who, according to national guidelines, should have received a specific intervention, patients who, according to other guidelines, should be offered a screening program, or other things that are part of the national sort of processes of care. And if you pop up in one of these, you'll get a message from your GP on your phone. A text message will pop up saying, we've identified you haven't had your blood pressure tested in the last year. Please come in so we can record a blood pressure, Steve.
So that's how we're using data on the front line in the UK. What about the Middle East?
Example.
Yeah. What about in the Middle East? Because both of us have had experience in both in Abu Dhabi, and also you and I were together for some really interesting conversations with the guys at Neon recently. And some of the things that they're trying to do from a data point of view seem a bit mind-boggling. So what's going on in that health economy as far as the use of data is concerned?
So an awful lot of innovation. How much of it has hit the front lines, I don't know yet. But I was on a call this morning with an entity in the UAE who are using data across a large group of hospitals to understand very specific outcomes of care for specific patient groups, and to understand what is driving good and less good performance, and therefore what they might do about it. So that's at a sort of individual hospital and hospital group level. There's long been work in the various departments of health, ministries of health across the Gulf to use data to understand quality of care across the providers. And obviously, it's an insurance-based system, and the insurers are very good at using data to understand risk at a population and individual level.
Because that's another area that I want to delve into in terms of use of data, because one of the things in those insurance-led systems, particularly that we talk about a lot, are the changes in the way that payer models work. So moving away from volume-based payer models, I do a thing, I get paid an amount of money to do it, towards a value-based, outcome-based payment system. How does data help us to move away from volume-based models to value-based models?
So as you know, I'm a huge fan of value-based care and value-based contracting. In order for an organisation, a provider organisation, to take on the management of a population, they need to be able to understand the risk of that population, the demand that that population is likely to put on providers over the next period, usually a year. In order to predict that, you need to understand that population. You need to understand a whole load of stuff around their risk of needing services, which is a mixture of biology, but also behaviour. Health-seeking behaviour varies hugely between populations. If you can access that data and you can predict risk within a certain boundary of accuracy, then taking on the care of a population for a specified, sum of money over a year is a really good way to put the incentives in the right place, because then the provider is incentivized to optimize the health of that population, so they seek the least care, because providing care is expensive. So it moves the incentive to the provider in order to improve health rather than provide health care. So, and this is what Americans call the ACO model, and is being adopted across the world because it puts the incentives in the right place. What it doesn't do is put the incentives as far as they can go, because the person who needs incentivizing most is the individual, because the person who can do the most about my health is me.
Yeah, and it's fascinating as well, because it is that, it's a whole other podcast if you start talking about incentives and perverse incentives to providers to provide more care, the lack of incentives to insurance companies to do preventative care because they think that they're actually going to bring the bill down for the next insurer, not themselves. But
I think that's changing. I speak to insurers relatively often, and the private health insurance model is starting to show some weaknesses. Costs are outstripping the ability of people to pay for health insurance, and I've certainly heard negative rumours that some insurers, for example, are predicting that they're going to have to stop covering cancer care within the decade because the costs will be unmanageable.
Well, again, it all comes back to this point that you raised earlier on about moving from sick care to healthcare and the incentives that sit around that. So, come back to where we started the conversation. We were talking about being able to provide population data-driven ideas around how an individual can manage their care, your risk of cancer. Our data tells us that your risk of cancer is X. Therefore, you need to change your diet. You need to do more exercise. You need to do, you need to look after yourself, essentially.
I just changed the language slightly there. People are not going to react well to being told you need to.
Yeah.
It's you might choose to.
Yeah.
Or it would be better for you if you choose to. So this is, I think that the nudge theory has been well disproven as not working.
Yeah.
But understanding how to motivate people based on predicted risks that they can't see yet and aren't impacting them now is a whole field of psychological science, which is one that it's not my area, I don't understand, but is going to be really important.
Well, I think you were there when I interviewed Mahmoud Al-Yamani, the head of healthcare from NEOM, and we were talking about exactly this point, the idea that the data provides the insight that provides the idea of what the person should do to improve their healthcare, but how you then motivate and incentivize that person. And I remember Mahmoud sitting there on stage and going, if you like watches, we'll give you an incentive program that allows you to earn watches if you exercise and you look after your diet. But it all comes back to the point that we raised earlier on, which is the idea that the data tells you how you can improve your healthcare in the first place, provides you with a system which is more preventative, more lifestyle driven rather than something reactive. And actually, how much is that? How much is it true that the revolution in healthcare data, the fact we're using so much more healthcare data, is driving that change from reactive sick care to proactive healthcare?
I think we're barely scratching the surface.
Yeah.
I think there is so much that will start to hit mainstream over the next, let's say, 10 years rather than 5.
Yeah.
But there is so much that can be done that we're not even touching these days. I think one of the problems is the big things that affect your life expectancy and healthy life expectancy are not easily impactable. Being born in a wealthy country, having a certain amount of money, choosing the right parents. These are not the kind of things that we're talking about. We're talking about, it's slightly rude, but, messing around about the edges. Smoking, not smoking is a big one. Diet and weight management. There is a terrifying change in the epidemiology of diabetes across the world at the moment. And exactly what is driving that is, to a certain degree, the increase in living standards and adoption of what's called a Western diet across parts of the world that didn't have access to calorie-dense nutrition in the way that it does now. So there's an awful lot to go at, but some of this is baked into our circumstances.
Yeah, and it's really interesting if you look at globally the way in which public health is changing and public health messaging is changing. We talked about perverse incentives a moment ago, and you talked about the US where every ad break on the telly is either an advert for fast food or an advert for hick medicine, snake oil stuff. I was talking to Dr. Nicholas Crisp, who's the Director General of the Ministry of Health in South Africa fairly recently, who was turning around to me and talking about the way in which his priorities have changed from, he was saying to me, he was talking about aid funding and the fact that if you want to do an AIDS program in sub-Saharan Africa, you'll have American donors falling over themselves to pay for it. But that's not his problem anymore. His problem now is diabetes, because you've got the issue of the flooding of the economy with cheap, calorie-dense, fatty foods. So all of this stuff. Yeah.
And this is where what I would call old-fashioned public health comes into play. You and I were in Amsterdam recently for the health conference, and compared to other cities I've been in, very few cars.
Yes. Yeah.
And it's designed for cycling, and everyone's on a bike. And this is around urban planning. This is around green spaces. This is about cycle lanes. This is about shaping the environment to enable a population to be a healthy population.
And on that point, it's interesting you talk about old-fashioned public health, because one of the interviews I've got coming up in the next few weeks is going to be with Duncan Selby, former head of Public Health England and head of the Global Public Health Professionals Association, currently advising the government in Riyadh. But coming back to the point around data, this is where you get that fantastic interaction of data. You talked at the top of the show about age, income, etc. You then add in it's that matrix of stuff that comes from all over the place, isn't it? How levels of healthcare vary from system to system, from city to city, and then why. Because there's a bit of a kind of thing there, isn't there, about the data tells us this, but why does it tell us this?
This is where you can dig down and down and down in the quantitative data, but at some point you need to get into the qualitative information. You need to get on the ground. You need to speak to people. You need to look at the environment. You need to understand the processes of care. And it's that interaction between data and the real world, where in order to truly develop that understanding. So I've been working with Duncan a little bit in Saudi, looking at the use of data for public health across the kingdom, and starting to do some thinking around how they can use data to drive public health across the kingdom, and they have huge ambitions.
Oh, massive, yeah. And it's fascinating to see what they're doing. I mean, I do think there is a piece there that if you want to see how data in healthcare will evolve over the coming years, go and look at what they're doing in the Middle Eastern health economies. Particularly, go and look at the ambition of what they're trying to do at NEOM, because there's an experiment for you in. I was talking to Graham Jelly, the strategy director at NEOM for healthcare, and he was saying to me, this is the first time in human history that somebody's designed a health system before the people have arrived. I can imagine how much fun you'd have trying to think about how you'd use data in a context like that. How would you? What would the first thing you looked at be?
I think it's a really interesting thought experiment, because there's a whole ton of stuff that the geeks like me would get super excited about, but it's got to be acceptable to the people who are going to live there.
And that brings up a whole.
This is a tension. It's an interaction. Because I can think of all sorts of data that I know I could do powerful and impactful things with. But are people going to want that level of monitoring? And are people going to be able to act on the level of feedback that could potentially be coming their way? There's a well-known thing around alert fatigue. A lot of hospital electronic medical records have had to turn off a lot of the alerting, because doctors are getting dozens, if not hundreds, of alerts a day, and they just ignore them because it becomes meaningless when you get that many.
Well, there's a thing, isn't there, about and I remember we did a project together a few years ago about digital triage, an AI-led digital triage, and the fact that as soon as you put a digital triage tool in the hands of a patient, the people creating that app or creating that tool are automatically become incredibly risk averse, because actually the moment a patient dies because the AI didn't diagnose properly, you're going to instantly that company will cease to exist. So instead they go too much the other way. Well, that could be skin cancer. It could be this. So at the end of the day, it was increasing the number of times that doctors were interacting with patients rather than decreasing it, which is kind of the point. Is that the same thing?
That wasn't quite what I was getting at, though. Yes, you're correct in the liability of patient outcomes and quite how that's managed in an online appified AI world is not settled at the moment, and is an interesting one. Where does that liability sit? Is it with the developer? Is it with the software company? Is it with the intermediary? Is it with the patient? Discuss. I think what I was getting at was more at the individual level. So if you're getting even, let's say, 5 nudges a day, 5 little messages popping up on a watch or a phone or whatever device they come through, telling you, you've been sat at your computer too long, get up and walk around. At some point, it gets really annoying and you stop paying any attention.
You're just going to turn it off, aren't you? Yeah. It's like the iPhone turning on until you just stand up. It's.
Well, but that's the thing. It's also, what is that actually based on?
Yeah.
What evidence is there that Apple have used to say, you need to get up every, I don't know, I don't have an iWatch, every 45 minutes to move around during the day? It might be it's a really powerful evidence base that's really relevant, or it might not be. I don't know. But this is where we need to be cautious of sort of received wisdom. The whole 10,000 steps a day thing. there's nothing underneath it.
Yeah.
It's not actually based on anything,
Well,
but it's received wisdom.
It brings us to a really, really interesting point, which is this point around governance, privacy, and how much we want our data to be used. Because, I mean, I remember a conversation that I was having relatively recently about the sharing of data. And a mutual friend of ours was talking about, the sharing of data is almost a civic responsibility. As good global citizens, we absolutely have to be sharing our data. Ethically sharing our data. Ethically sharing our data with people who are going to use it ethically. How much do we trust that at an individual level and at a system level, that actually, how much do we know it's being used for the right things? Now, there's a can of worms.
Yes, I completely agree that sharing data for the public good, so it can be used to improve the care of our fellow citizens, our fellow human beings in a sort of international context, is an ethical responsibility. And to get into the weeds, there are data security technological approaches that can do that safely. The weaknesses are not technological weaknesses. The weaknesses are human weaknesses.
Yeah.
The weakest bit in any data security is the guy sitting in the chair. It's not the computer.
Mm-hmm.
I understand why people have concerns, but the slightly inelegant phrase that I've used when I've had to describe this, standing on a podium being howled at by the audience, is I work at a population level. I'm interested in populations and groups and people. Yes, your personal data is within that population, but I'm really sorry, I'm not interested in you. You don't matter to me, mate. So it's about aggregate.
Yes.
And then using that aggregate to drive algorithms, models that predict at the individual level. And that understanding that sharing your data contributes to the aggregate, not, I don't need to know that you're you.
Yeah.
I just need to know that you're a man of a certain age with these various, factors in your health record, who lives in this part of the world. Then I can start to build models and predict things for all the other people who are men of a certain age with all the same health factors who live in a certain part of the world. The only time at which the data comes back to the individual level is to provide care to you.
Yeah, that precision medicine piece. Yeah.
And that re-identification thing should only happen at the point of care.
Yeah, no, absolutely. Absolutely. And it is fascinating, isn't it? Because you do get this point around anonymization of data and the screaming, scary headline of, well, it might be it can be de-anonymized. Somebody could go in there and kind of work out who you are from amongst this aggregate and find the question is, why would you want to? What possible reason?
Sorry.
Yeah.
I'm sorry, you're just not interesting. Why would
I? Is that me on a personal level or just generally?
Well, take it how you wish.
But there is that point. I mean, it's always the de-anonymization point is not the thing that people should be worrying about. It's what data is being used for that they should be worried about. Because I think any system or organization that's looking at sharing healthcare data needs to be careful about the why. Because at the end of the day, isn't one of the things that populations worry about in terms of sharing care data, the Amazon problem? We've all sat there and gone, oh my God, how did Amazon know that I wanted to buy that thing? I didn't even know I wanted to buy that thing, but they do. Are we not? Is that not something we should be more frightened of? Is actually potential misuse of our healthcare data?
I've been involved in all sorts of discussions around sharing of data and what data is shared and how granular it is. And I always come back to the concept of it's all about purpose.
Yes.
What is the data being shared for? And is that a a good purpose or a not good purpose? And who decides what good is? And this is a political question, and is one that many countries, most countries, are taking at a national level. Countries are putting in all sorts of rules around data being required to be hosted within national boundaries. Though the new European data space is going against that, and I think in a very, very positive way, almost reversing the tide by saying it is ethically appropriate, and you should be sharing your healthcare data across international boundaries. This is in the EU, because it is ethically appropriate and a public good. And I applaud that.
But is there an issue then? Because that again gets into another really interesting question, is because the ethical imperative for sharing data, because if we share data on a global level, we have more population health data, we have more data about how humans work, and we're able to extrapolate more out of it. That's all great. But the world is divided into countries and corporations and et cetera, and some people have more data than others. Is there a danger of the corporatization of healthcare data? So in other words, organizations, nations, providers, payers, suppliers holding data hostage because they want to use it to make money as opposed to using it for public good.
Absolutely. And the defense is by sharing.
But how do you, and this is really interesting because we both live in the UK where we have a single payer system, National Health Service. As a result, all of our healthcare data is available at a national level. Whereas if you look at a health system like Abu Dhabi or Dubai, Saudi, US, anywhere where it's insurance led, that data sits in pockets. So providers will have data. Okay, how does it work in those economies?
I can speak from experience in some, but not all of those systems. But they have national data collections, where the insurers are required to submit person event level data to national bodies.
But that has to be mandated at a government level in order to.
But that's exactly the same as in the UK. It's no different. It's just the route by which it's brought together and aggregated is different, but it's the same.
And presumably the level of data and the level of information. Is there a need?
Not really.
Well, I was going to say, is there a need for ensuring that across systems we're comparing apples with apples? So that the same data is being collected in different systems.
So standardization is massively important. Because you can't build models based on very large data sets if the data comes from different sources and is not comparable. So there are a number of different bits to this discussion which need sort of picking apart. One of which is standardization of data models. And the world is slowly sort of, as far as I can tell, starting to adhere around the OMOP data model for healthcare, which is increasingly becoming a standard data model, which will enable all sorts of good things related to analysis, but also interoperability between systems. So that's a very powerful thing. The other thing, once you get standard data models, is standard definitions of the elements within the data model. And that's a little bit more tricky, but is the next step. And then you get down to the third level, which is the ability to compare variables from one organization with another. So machines in laboratories are routinely calibrated against standard samples, so that a result from one hospital is comparable to a result from another hospital. And it's at that level that this is going to get really difficult.
So look, we've only got a couple of minutes left. Closing question. What's the biggest single thing that I, as a patient, as a consumer, as an individual living within a health system, what's the biggest single thing that use of data is going to do in the next 10 years that's going to impact my life?
Okay, I'm going to give you two answers. The negative answer is possibly not much, unless you get in real trouble from a health perspective, in which case it might be that the treatment that you receive is optimised based on person-level data about you that can be used to select a more effective treatment than a generic treatment. And by generic, I mean most of modern medicine is based on clinical trials. And this example is going to fall apart in a second. Clinical trials are very carefully designed and constructed with very carefully specified entry criteria and exclusion criteria for the individuals in those trials. And many of those are designed around middle-aged white men. This is when the example falls apart, because you are a middle-aged white man.
You noticed.
But that means many of those studies, the results, don't actually apply to people who aren't middle-aged white men. But this is where large-scale data can start to understand the outcomes for patients from specific treatments across all sorts of population segments. And they are going to be very different to what we see in traditional clinical trial type outcomes. So that's potentially really exciting, because that's sort of the personalisation.
Yeah, and that whole point about the use of data in clinical trials and the revolution that will create in terms of our ability to provide effective medicine is probably a really good answer to my question.
I'll do my best.
And we're out of time. Simon, thank you so much. It's been an absolute pleasure. I think we need to do another one of these. There's so much more we could still talk about. Thank you very much. Cheers.
Plenty.